Good evening, colleagues and friends who joined us this evening. So my talk tonight is Lost in Translation, Doctor Statistical Illiteracy and Miscommunication Risk. Right, so the objective is from this talk is to characterize collective statistical illiteracy and our difficulty as physicians to assess risk and communicate risk. Also to illustrate our statistical illiteracy and our problem is how uncomfortable we are with uncertainty. And I hope that I will end up by describing simple tools that will help us to deal with the statistical illiteracy to help ourselves and our patients. I have no disclosures to make other than the fact that I am extremely numerophobic. Numbers is the last thing I will feel comfortable with. There is an orphan code that there are 3 types of lies: lies, damned lies, and statistics. And this code seems to be like an attack on statistics. Yes, you can use statistics to disinform, to misinform, to manipulate people. However, in our world, it's very difficult to get into facts based on, draw probabilities based on past empirical data unless we have some grasp of statistics. And the problem with the statistic is, like anything invented by humans, it's as good as the user and the intentions of the user. And I got this quote handy that if you torture data long enough, it will confess to anything. So before we go any further, I will start with asking this question. We as physicians, we order investigations every day, and it is our job to interpret results to patients. So if a screening test to detect a disease with a prevalence of 1 in 1,000 has a false positive rate of 5%, what is the chance that a person who tested positive for the screening test is actually having the disease? So pick your answer. Anything, it could be anything from 2% to 95%. So the aim of this question is calculating the positive predictive value of a test. Normally, when we order investigations and we get the result, we don't actually factor in the pretest probability in assessing the positive predictive value of a test. Right, so when this question was submitted to healthcare physicians ranging from students to house staff to attending physicians, the most common answer was 95%, while the correct answer for this question is 2%. So there was a large overestimation, and this is a significant error that has a considerable impact on the diagnosis and therapeutic management. So it seems that we are, as physicians, we have that sense of certainty about the accuracy of what we order. If you stay with me toward the end of the talk, I will give you a simple tool how to calculate the positive predictive value of a test. Right, so we healthcare physicians approached by people, they look to us as superheroes, as lifesavers, but there is enough evidence that in a lot of time, it's actually the blind guiding the blind, like the example that I just presented earlier. So there is enough evidence to suggest that only very few of us actually understand healthcare statistics. And unless we understand healthcare statistics, informed decision-making will remain more or less close to science fiction rather than a day-to-day reality. And the reasons or the factors behind our difficulties with healthcare statistics usually largely caused by 2 factors. One, lack of training in risk assessment and risk communication. And the second factor is bad presentation of statistics that can be quite misleading. One of the difficulties we have as physicians, we use the terms risk and uncertainty. We interchange these terms, although they totally mean totally different things. So if we manage to quantify uncertainty into a probability based on vast statistical data, that is the risk. And when it comes to certainty, there are very few things in this world you can be certain about. Benjamin Franklin once said, in this world, there is nothing certain except death and taxes. Everything else is either risky or uncertain. The classic example of risk is the gambling or the slot machines. Whenever you go to the slot machines or the gambling, regardless of how clever you are or how lucky you are, the odds are against you. The odds are in favor of the owner to make money, and you are more likely to lose. Uncertainty is almost everything else. Healthcare, human relations, stock market, weather, these are all uncertain things. When it comes to dealing with uncertainty, it seems that we are struggling. It's something that we can't tolerate. So we have a tendency to downgrade from certainty to risk by what's called the turkey illusion. And this was coined by the Scottish philosopher David Hume. And we also have a tendency to downgrade from risk to certainty under what is called the zero risk illusion. What we need to remember that when we ever make medical decisions, there is no zero risk option. There is no option that doesn't have negatives or downside to it or cons. The option is between a probably risky option with a probably less risky option for this particular child, this particular family. Right. Well, one of the examples of ubiquitous statistical illiteracy, the tragedy of Sally Clark, is probably one of the most famous miscarriage of justice in contemporary British legal history. So Sally Clark is a solicitor from South Manchester. In 1996, her first child died unexpectedly at a few weeks of age, and the case was concluded as sudden infant death without further workup. A couple of years later, her second child died in a similar manner, and because both deaths happened when she was the only one who was attending the children and her husband wasn't around, so she was arrested and tried for the deaths of her children. Medical opinion were divided about, is it just an unfortunate sudden infant death, or is it a matter of infanticide by a mother? So the prosecutor asked the help of expert witness, and the expert witness, a pediatrician, he testified that the chance of 2 children suffering sudden infant death is 1 in 73 million. And he came to this conclusion at the time. The latest data, the incidence of sudden infant death in a middle-class Caucasian non-smoking family in the UK is 1 in 8,500. And calculating the probability of independent factors, if you want to calculate the probability of 2 independent factors happening together, you time the probability of each by the other. And if you time 1 over 8,500 by 1 over 8,500, you will get the 1 in 73 million. He also added that this will happen, 2 sudden infant deaths in one family will happen only once every 100 years in the United Kingdom. In 1999, Sally Clark was sentenced to life for killing her children. The expert witness who testified in her case is a highly distinguished pediatrician called Sir Professor Roy Meadow. He is a highly decorated and distinguished pediatrician. He was the ex-president of the British Pediatric Society, and he was the first president of the Royal College of Pediatrics and Child Health. He was knighted by Queen Elizabeth II for his services to child health. He was very famous for his child protection and expert witness work. He is famous, he was the one actually who coined the term Munchausen by proxy when he reported a series of cases of fabricated illness. And he has a famous child protection book, and in that book there is a rule of thumb which is known as Meadow's Law. It says in a single family, 1 sudden infant death is a tragedy, 2 is suspicious, and 3 is murder until proven otherwise. So Sally Clark was convicted in statistics. Then after several years in Her Majesty's prison, the Dr. Sir Roy Meadow statistics, flawed statistics were challenged, and she was released from prison. And she has teamed up with John Batt in writing a book about her experience, A Mother's Fight for Justice, Stolen Innocence. However, despite her acquittal, she didn't manage to get her life together. She has problems with alcohol, and one morning she was found dead in her South Manchester home. As with regard to Professor Sir Roy Meadow, his fate wasn't less dramatic. He was the victim of attack by MAMA, which is a group of highly motivated ladies, the abbreviation for Mothers Against Munchausen Allegations. Those ladies were behind his scalp. The tabloids dubbed him as the doctor who broke up families, and eventually he was suspended from the GMC. So the lessons from Sally Clark's case is that expertise is too narrow. Being an experienced pediatrician, it doesn't mean you are experienced statistician. And it also demonstrated painfully that statistical illiteracy is ubiquitous, not just in healthcare, but also in legal departments. When we assess the efficacy of medical intervention or new drugs, or we compare two interventions, we usually use the risk reduction. And there is usually 2 ways in presenting risk. So let's examine them. So if the fact says that if you use aspirin daily for 5 years, it reduces the risk of heart attack from 2% to 1%. So if we presume there is a doctor called Dr. Absolute, Dr. Absolute will tell you that if you use aspirin once daily for 5 years, it will reduce your risk from 2% to 1%. The absolute risk reduction is only 1%. However, on the counterpart, Dr. Relative will say that the aspirin, the risk of reduces the risk from 2% to 1%, which is 50%. Absolute risk, whenever we looking at the efficacy of intervention, absolute risk is more useful in conveying the true impact of an intervention. Yet, it is usually the relative risk that involves exaggeration that is usually reported in research and media. In this paper, the researchers looked at the mismatching framing, looked at how relative and absolute risk are presented in high impact journals. And they found that in 1 out of 3 cases, there is mismatched framing. The benefits are usually reported in relative risk, i.e. the big numbers, and the harms or the side effects are reported as a small number or the absolute risk. it's very difficult to understand the reason for this discrepancy. Obviously, it is physicians and patients find it very misleading. Whenever we compare the survival rate, the malignancy in oncology patient, 5-year survival is one of the most commonly used survival statistics. However, in the context of screening, it is extremely biased metric. So we can't use 5-year survival to compare the efficacy of screening program by comparing a screened and non-screened population. To know which population is doing better, we need to compare the overall mortality rate rather than the 5-year survival. And we humans have a tendency or urge to try to know things early, but knowing too early is not always a good strategy. It can be harmful. It doesn't come without its negative side, without its cost. So screening profoundly biases oncology survival statistics in 2 ways. It affects the time of diagnosis, so it inflates the time between diagnosis and death in what's called as lead time bias. And it also includes people with non-progressive cancer, so it will include in the statistics those overdiagnosed and those with false positive. If the meteorologist says there is a 30% of chance of rain tomorrow, which of the following statement is correct? Does he mean that it will rain 30% of the time tomorrow, or it will rain 30% of the region, or it will rain 30% of the days like tomorrow, or 3 out of 10 meteorologists believe that it will rain tomorrow? This example illustrates our difficulty with single event probability. A single event probability is a probability statement that an event will either happen or not. It will either rain or not rain. And the single event probability is a steady source of confusion because the reference class the probability refers to is left ambiguous. So the same ambiguity occurs when we're communicating a clinical risk, such as the risk of a drug side effect. So how can we reduce the ambiguity or misunderstanding when it comes to single event probabilities? There are 2 tools. First, we need to specify clearly the reference class of the probability event, or we only use frequency statement. So instead of saying 30% chance of side effect, we'll tell the patient that 3 out of 10 patients will report a side effect of this intervention or this medication. The chance of a test detecting a disease is typically communicated in the form of conditional probability. However, there is enough evidence that we physicians have trouble distinguishing between sensitivity, specificity, and the positive predictive value of a test. Sensitivity of a test: if a child has a disease, the probability that he or she will test positive is 90%. This is sensitivity. Is often confused with if a child has a positive test, the probability that he or she has a disease is 90%. So the conditional probability of A given B is often confused as that of B given A. What we need to remember is that conditional probability refers to different classes. The sensitivity of a test refers to those with the illness, the specificity to those without illness. And using transparent representations such as natural frequency clarifies the reference class. Let's look at 2 ways of presenting information. So if the probability that a woman had a breast cancer is 0.8%, which is the prevalence. If she has a breast cancer, the probability that a mammogram will be positive is 90%. This is the sensitivity of the mammogram. If a woman doesn't have a breast cancer, the probability of a positive test is 7%. So this is the false positive or the specificity. If they ask us the question to calculate the positive predictive value, a woman who has tested positive, what is the probability that she actually has a breast cancer? When the conditional probability is presented like this, we find it quite difficult to calculate. At least change the same information into natural frequency. So we know that 8 out of every 1,000 women have a breast cancer. Out of those 8 women with a breast cancer, 7 will test positive on mammography. And out of the remaining 992 women who doesn't have a breast cancer, because of false positive, 70 will false positive. A woman who has tested positive for in mammography, her chance of being actually having breast cancer is 7 out of 77, which is around 9%. So what could we do? How can we move from innumeracy to insight? So when it comes to single event probability, instead of just leaving the reference class open or ambiguous, so instead of saying there is a 30% chance of side effect, we will use natural frequency, and we will say 3 out of 10 patients will have a side effect. And when it comes to relative risk and risk communication, we should always use the absolute risk. A woman who undergo mammography, if you use mammography for 10 years for ladies above 50, 3 will die out of because of 3 out of 1,000 will die because of breast cancer, compared to 4 in the non-screened population. So the risk was reduced from 4 per 1,000 to 3 per 1,000. Usually on breast cancer campaigning, they will say that mammography reduces the risk by 25%. However, the natural frequency or the absolute risk, we should tell the ladies if they screen for 10 years, 1,000 women, we will save only 1 life. When it comes to conditional probabilities, so instead of using the confusing sensitivity, specificity, or positive predictive value, I suggest using natural frequency. I will go back to the first question, how to calculate a positive predictive value of a test. So the question was, if a test to detect disease with a prevalence of 1 in 1,000, and the test has a false positive rate of 5%, what are the chances that a person found to be positive in screening actually having the disease? So to do this, we will use what is called the 4-fold contingency table. So at the top, the test result either positive or negative, and on the left side, the test is positive or negative. And we know we will use 1,000 cases. So we know from the prevalence that the disease prevalence, this is a screening test. So the population, the tested population is asymptomatic. So we know from previous statistical data that the risk is 1 in 1,000. So out of the 1,000 people we are screening, 1 is actually having the disease and 999 are healthy. For the simplicity of calculation, we presume that our test has an excellent specificity and sensitivity, and 1 person with the disease has actually tested positive. We also know that the test has a false positive rate of 5%. So out of the 999, around 49 of them will have a false positive test, while the remaining 950 will be negative. So on this side, we have 50 people tested positive, one have the disease, and 49 are false positives. So the positive predictive value of this test is 1 divided by 50, which is only 5%. In contrast to the physicians, when they were presented with this question, the most common answer was a huge a huge exaggeration of the positive predictive value of test. The most common answer was 95%. Right, so with this, I will come to my final slides. I encourage you and myself to acknowledge that we are statistically illiterate. This is the best thing we could do to ourselves and our patients. And we also need to admit that our statistical illiteracy and our innumeracy, it prevents us from meaningful quantification of risk and uncertainty. And this, in consequence, impairs our ability to communicate risk to our patients. The other message is that one of the reasons of this, our inability to assess risk and communicate it, one of the causes is poorly presented statistics, such as the absolute risk, relative risk, or the difficulty with calculating positive predictive value. And this impacts the way we communicate risk to our customers with extremely serious consequences. So instead of using single event probability, always go for frequency statements. When it comes to assessing risk, if anyone tells you about relative risk, they are about to cheat you. Always ask about the absolute risk. And when it comes to survival rate among screening in oncology, 5-year survival is a completely biased metric, so you should always ask about the total mortality rate difference between the screened and unscreened population. And using natural frequency instead of conditional probability helps to make the statistics more transparent and for us to get the message behind. With this, I complete my presentation. I'll leave you with my references. It's a beautiful group of books that tackle the problem of statistics, uncertainty, especially in healthcare. I found it both interesting and insightful to read.
Abdelaly, thank you very much for this interesting and really thought-provoking talk. And thanks for the hard effort in going through all those books and summarizing, whatever you've learned into this interesting lecture. Really, you seems to be promoting that doctors should be very much knowledgeable about statistics. Do you think, for example, statistics has to be a must or a condition that everybody who goes into medicine, there should be, sort of part of the subjects or mandatory subjects is statistics, for example?
Right. So essentially, we humans, we have problem with anything abstract. We love the narrative, we love story, we love the gossip, but anything abstract or numbers, it doesn't come naturally to us. And the problem, statistics is a mandatory in when you, I'm sure you remember our undergraduate years. Statistics is mandatory for all of us. But I remember the way we were told. It's so painful. It's so dry. It's very difficult to get to the spirit of it or to apply it. So there's definitely a need for training. but there is also a need to train and teach statistics that is transparent and practical.
Yeah, you're quite right. I mean, they taught us, you know, I don't know, the mathematical statistics. Perhaps
True.
it should be more towards, you know, medical statistics with a
Absolutely.
flavor into medicine, isn't it?
Absolutely.